Hi guys, it's Dr. Gillard. This is a review for the final examination in Differential Diagnosis 2 Lumbar Spine. This is specifically for the summer of 2015, and here's your review. I'm going to go through the last few weeks. So off we go. If you study this, you should do pretty good on the final. Remember, it's not 100% comprehensive, but this will definitely give you some things to clue in on here. All right, let's go right through this part. Let's see, I would definitely know this. What's this called? I guess we'll quiz you a little bit as we go. So that is the step-off sign or the step sign, and it's indicative of a spondylolisthesis. It's a divot there. You're palpating along the lumbar spine, and you feel a drop-off there. Step-off sign equals spondylolisthesis. So be careful with adjusting, right? Should better get some x-rays. Okay, I would know that. The discogenic spondylosis, remember we talked about that? And what is that? See the sclerosis here, the end plates? That clogs up those marrow channels, right? The marrow channels are needed. If the marrow channels get clogged with this osteosclerosis, this thickening here, the disc cells literally starve to death and they don't produce proteoglycans. The disc gets very dry, can get thin, it can rip. And there's that same thing. I would definitely know what these marrow cavities or marrow channels, you could call them. Remember, we talked about this is one of the causes of degenerative disc disease, how these sclerose shut. Then you get cut off of the nutrients, right? And the cells die. I think you got that pretty good. Don't need to know that. I don't think that's more for your information about fusion. Definitely need to know about this. Talked a lot about this. What is this? Okay, the end plate, look at the disc size. The disc is decreased. The margins of the end plate are blurry. It's a big pocket of pus. This is osteomyelitis of the spine. Pyogenic spondylitis is another word for it. Pyogenic spondylitis. Remember, what are the two types, the two flavors? Definitely know that. Pyogenic spondylitis is a bacterial infection of the spine, and tuberculosis spondylitis is an infection by the, let's see, do we need to know that? I would definitely know these risk factors, know these pretty well. Diabetes is a risk factor. History of past spinal procedures, we went over that and over that. Definitely know that. Remember that's a remote site infection. It's not a primary infection. Either one of these spinal infections, they're secondary. They're spread by the blood. They start in other places like the lung or pelvis. They could indicate a malignancy as well. Your patient shows up with this, you better have them checked very carefully for some type of malignancy. HIV infection, long-term steroid use. Yeah, I know this as well. Fever. Not all of them have a fever though, right? Only about a third to a half of them have a fever, so they might not have a fever. Okay, I think we got that. You should know Staph aureus is the culprit with the pyogenic type. You should know the name of that gibbous formation. And you should know that's Pott's disease, which is third world countries, classis gibbous or hyperkyphosis. So we should definitely know a little bit here about tuberculosis of the spine, Pott's disease, Pott's spine, Pott's disease of the spine, know those AKAs. Relatively uncommon in the Western world unless patient has HIV, so it could be an early sign of HIV. Know the creature, Mycobacterium tuberculosis is the creature. And there, know that, I already said that, always secondary to hematogenous spread from a primary infection. And the spine is by far the most common site of involvement. Okay. Followed by the hip and knee. It wasn't, I think I said the pelvis. It's hip and knee are the other sites. Now, we definitely want to know something about this. Remember we talked about this is actually my MRI here. So, 50-some-year-old male, failed discectomy. Remember this view here? This is the axial view. What's that? That's the thecal sac traversing right S1 nerve root. This is the L5 disc. Traversing left S1 nerve root. What's going on here? Why does it look so weird? All of that is scar tissue. Remember we talked about that? That's all the scar tissue. So that nerve root is anchored right down. And it's got a little bone spur there to boot. Just right at the end of my little arrow there. Stenosis, this is kind of not the greatest view, but you should still immediately recognize what this is. This is a sagittal view, and you can see the spinal cord is supposed to be 20 millimeters. It's just very narrowed all the way down. What's this orange thing? That's a cut line through the sagittal. We look down on the cut, and this is what we see. There's the disc, and where's the thecal sac? I mean, everything's together. There's so much stenosis. This is a T2 weighted image. You can't see anything. So this is central stenosis, severe central stenosis. I'm not going to go through this. Make sure there's one or two questions on those two algorithms. MDs write medical medication poorly. So make sure if you get a passage, make sure you'll be able to check these things off, because you're going to get a passage and it's going to say what part of the history is missing. So you'll have to figure that out. I would know this one as well. Right? This is it a mid-sagittal or perisagittal cut? It's obviously a sagittal cut. It's off right through the IVFs. How come we can't see them up here? Because the patient has a little scoliosis, but we can see these bottom three quite nicely. And all of these are compressed a little bit, but you can still see the exiting root here of L4, exiting root of L5, and then make sure you can see this, what's going on here. There's the root back here. That is all disc herniation material. So this is a foraminal disc herniation, and it actually spills over to the far lateral region. So know that picture. And here's the axial view. You can see how that's really nice, isn't it? You can see how the herniation is right in the neuroforamina and a little bit far lateral. So there's what we saw. Very nice. And know why the straight leg wasn't it positive? Well, stretching the straight leg raise test typically does not affect the exiting nerve roots above L4. So never checked if there's research. I probably should, but that's very well known anecdotally. Far lateral herniations, the roots just don't stretch for whatever reason. Definitely know this. What's going on here? Give you a second to look at this. Patient entered with right upper quadrant pain. She had pain wrapping around from the low back into the right upper quadrant. She had a fever. She was nauseated. Make sure you know this right there. Gallstones, right? Cholithiasis, but just say gallstones is good enough. There's the classic signs. Should add to that list there. I think I did on the new one, that it does tend to refer to the back, and it can wrap around. And this is epigastrium, which is more general. It's the right upper quadrant. It's pretty classic for this. All right, make sure you can tell what this is. There's one a lot easier than this. This one's a little sneakier to see. So you need to know about this condition. Now, that's good, spondylosis, but I'm not. Now, this patient, let's see, would they have any symptoms? I don't think they'd really have any symptoms. Just came in with low back pain. They got, see all these bone spurs here? These are almost growing together, these two, so that's just spondylosis. little thinning of the disc here, but don't forget to catch this. This one's a lot harder. See all this material? Let me outline it. This is this is abdominal aneurysm. All of this. It's right here, and it's over 50%. It's not a gigantic one, but it's big. It's definitely an abdominal aortic aneurysm. So make sure you catch that. Patient needs to be referred immediately for an ultrasound. Okay, what are the three diagnoses here? Let's see. We talked a little bit about this one, where you get modic changes, rat bite erosion, and a thin disc, probably annular tears inside this disc. That's isolated disc reabsorption. Isolated disc reabsorption. So I would definitely read over this. Know what's made up of modic changes, rat bite erosion, and it's associated with annular tears and a decrease in disc height. Highly associated with annular tears. I would know this as well. What do we got here? Let me give you a minute to look at that. Okay, this is obviously an overhead view of the disc. Not the greatest MRI, but the patients are going to bring these into your office. They're not always beautiful. So this is the disc. Here's the slingshot. The posterior arch is back here. Facet joints are here. Here, a little bit fluid filled, and that may or may not indicate a problem. That's very debatable. The black little cat eye things here, this black is all ligamentum flavum, which is thickened. So this patient had, this is the left side, horrible low back pain on the left side. And what do you see? What's this? How come we're seeing this white in here? Right? That's a circumferential annular tear. Circumferential annular tear, and he is stenotic. It's kind of a squeeze here. It's mild to moderate stenosis. But the big thing here is this annular tear. Are these always painful? No. But can they be symptomatic? Absolutely. They can create horrible pain in some patients. And I think I have about at least 3 of these on the new test here. So we're going to give you some cases here. Try to let you try to figure things out. Definitely need to know that. High pros never idle. There's going to be a question on that. Just like the history question, you'll get an examination. I forget which one it is, but this is definitely on there, so make sure you know that. We've seen that before, haven't we? Or one very similar to that. Patient comes in with a temperature, fever, never had back pain before, had some type of spinal procedure 4 or 6 weeks ago. Osteomyelitis of the spine. Just know that spondylolysis, we said that, remember that's the fractured pars without slip. They can also cause radicular pain down the leg. Why? Because of this beak. And this is a lateral or medially growing beak here. Here's the spondylolysis here and here. Facet joints are here. This should not be here. This should all be solid bone. You can see the stress shielding, right? On each side. Remember not stress shielding, reactive sclerosis, right? There is one about reactive sclerosis. It's not this image, but anyway, know the beak spondylolysis can cause radicular pain. What's radicular pain? That means that you believe the nerve root, an injury and inflammation to the nerve root is causing radiating pain down the lower extremity. Sciatic is kind of a catch-all term. I don't really like it, but I think we're stuck with it. Remember, there's a difference between radicular pain and radiculopathy. What's a radiculopathy? That means that your examination found sensory change, numbness in the foot, decreased reflexes, and decreased muscle strength. At least one of those. There's got to be positive neurological findings in order for there to be radiculopathy. Definitely know these, the compressive lesions. Know the things that can cause radicular pain or even radiculopathy. Facet cysts, spinal cord tumors of the nerve root sheath. I think you should know the dermatomes of the foot as well. This is lateral out here, so that's S1. On the top is L5, and on the inside is L4. Got to know those. You already know those though, but you better know those. You should definitely know the orthopedic tests. I'm just thinking here as I'm going through. Know which orthopedic tests are key for finding a disc herniation, or for diagnosing a symptomatic disc herniation. Straight leg raise, slump test, the well leg raise, and Valsalva's test are key. Bechdru's test as well, which is the seated straight leg raise. That's an easy one, but definitely know this. Okay, again, here's these. Remember I showed you that onus program, how you can set this up. So there's a cut right through the disc, the L4 disc. I don't have to label this, but if you don't say L4, you're going to get this wrong. So that's obviously, from here we're pretty sure it's a herniation, but we need to go overhead to see difference between a bulge and a herniation. It's a focal outpouching of the disc right here. This is all herniated disc material. So this is way bigger than 7 millimeters. So this is an extrusion, a disc extrusion of the L4 disc. And more specifically, it's not perfectly in the center. It's a little bit off to the left. Remember, sides are reversed. So it's a left paracentral disc extrusion. A lot of questions on spondylolisthesis because you are going to see these things like crazy. So what type of image is this? Is it an X-ray? No, it's a slice. So remember we went over in great detail where the pars was, and the pars is right here. So this is a spondylolysis of L4. Is it bilateral or unilateral? We don't know. This is just one slice through one of the parses, and so we're not sure. From this image, all we can say is it's at least a unilateral pars defect, or you should definitely call that spondylolysis of L4. Now, if this was an X-ray where everything is squished flat, then you could say it's bilateral. You would be sure it's bilateral because there's clearly a huge channel here. But not on a CT. We're only seeing one side, only one pars interarticularis on this view. And let's see, definitely know this one. Okay, I would know this whole case. This is a lady who came in. She got food poisoning and just vomited. Not one of those forceful, hard vomiters. You probably know the type. Some people vomit nice and gracefully. Some people, they can break blood vessels in their eyes. It's a very strenuous event. And she obviously did something here. So this is a compression fracture. And you have to go a step further. I'm going to ask you for a couple diagnoses. We don't care about the staples, the hyperlordosis. We don't care about. It's clinic. If you get this vignette here, right here, what's clinically important? It doesn't matter about the hyperlordosis. What does the vomiting have to do with this fracture? So we have to look at the bone density. This patient's got pretty significant osteoporosis. So osteoporosis, the answers would be osteoporosis and compression fracture of what level? Here's the sacrum down here, 5, 4, 3, 2, 1 of the L1 vertebra. I would know this image, or one similar to this. This is patient's low back pain, comes in with low back pain, pain upon Kemp's test, pain upon extension. When you extend, this is the front over here, this is the back. When you bend backwards, it extends. You can imagine just compressing this. And now, is this a bilateral or unilateral spondylolysis? Right? And you could maybe call this spondylolytic spondylolisthesis because we have maybe a tiny bit of slip here. Right? Here's the posterior corner, L5, posterior corner of S1. So it's grade 1 spondylolysis. But it's definitely bilateral because you can see clarity right through both pars interarticulari. Remember, this is not a slice. This is the right and left. This is everything smashed by a steamroller flat. So L5 spondylolytic spondylolisthesis. If you called it an isthmic spondylolisthesis, that would be fine as well. You can call it spondylolytic spondylolisthesis or an isthmic spondylolisthesis. Don't call it a degenerative spondylolisthesis, dysplastic spondylolisthesis. No, none of those other ones. It's either those ones I just mentioned. We've seen this. Here's another example. So obviously it's an infection there. So with this vignette here, they come in with low back pain, but the key is they have a fever. The diabetic, they have a fever, severe back pain, never had pain before. So do we care? Do we care about the little spondylolisthesis here? No, we don't care about it. This is all we care about. Look at this. It's all blurred in space, little decrease in disc height. This is an infection. This is osteomyelitis of the spine. I would know this picture. Okay, how old is the patient? It's a riser sign. And then we got spina bifida. And if this is an athlete who comes in, severe low back pain, it's on extension and Kemp's test. Extension hurts. We take an x-ray. What do you see? Well, we don't care about the riser sign. We don't care about the spina bifida. But look what we have here. That's the reactive sclerosis, right? This is the pedicle zone here, right? Or the pars right underneath the eye, the pedicle here. That's the pars interarticularis. Look at this one. Super white. Okay, reactive sclerosis. There's a little lucency right there. So that's a unilateral spondylolysis. Do we call this a spondylolisthesis? No, you can't tell. I can't tell if it slipped or not, but I can definitely see the reactive sclerosis here, and I can see the lucency, so that's a unilateral spondylolysis. Okay, take a look at this one. You know something like this is going to be on there. This is a subtle one. So look at the pedicles. Patient might even be a tiny bit osteopenic. Whoops, that one's a little wider than that one. Doesn't look to be like a gas bubble. So what could that be? Osteoid osteoma. Osteoid osteoma. And then make sure, if we're not sure, which I mean, it's hard to catch that. You could order what test? Bone scan, and there it is. Definitely know what this is. Okay, what would you call that? There's definitely some sclerosis there. Compared to this, L4, the Scotty dog is oblique view, right? Look at how fat that pars is. Look at how narrow this is. Right? So that's a hypoplastic pars intraarticularis. And that there might be a fracture, stress fracture in there that we just can't see right now. So if this young athlete fails the bracing, I mean, you might have to order a CT on this patient. If you don't see it on the CT, you might have to order a bone scan to get to the answers here. We talked about the importance of flexion extension. You know what this is. I definitely know what this is. I like this. Okay, this axial view. So we got good. You got that one. Central stenosis, severe, moderate to severe. But so you'll get that one, but you're going to get half off because you missed the other diagnosis. I'm going to ask you for 2 diagnoses here. That's right, you missed this. Look at the posterior arch is guillotined right forward. Right? There's the superior articular process of the bone below. Remember in a degenerative spondylo, it's the superior articular process of the bone below. that slips. This one's hanging on. This one is slipped. It's way back here. So this is a degenerative spondylolisthesis. And this superior articular facet or process slash facet, right? The facet's the actual thing that slipped, but the facet is contained within or on top of the superior articular process. However you want to say it, this guy has dropped the ball. The superior articular facet or superior articular process, which contains that part of the facet, has failed. Degenerative spondylolisthesis. Remember, make sure you know where the pars is on these sagittal views. It's right here in this pink area, pars interarticularis, because that's the area you want to check. Know what that is. This is an A to P view, so you could say it's isolated disc absorption. Maybe. We can't tell if those are modic changes because this is a CT. The important thing here is, what do we have? Good, a lateral listhesis. With disc is shot, we got rat bite erosion, but this is a lateral listhesis. Then we do our flexion extension views. Talked about all that stuff. Spondylolysis, we've been talking about that. I mean, know these little points here. These are real easy to make questions out of, right? Which of the following is not true about spondylolysis? And when I say which of the following is not true, don't get trapped in that. You guys have taken tests a lot by now, but you can also reword it and say which of the following is a false statement. Don't get fooled, tripped up by that type of questioning. So it's one of the most common causes of low back pain. I think that's pretty important in athletes. Should know that. It's considered an acquired stress fracture. I think that's very important. They used to think it was some congenital thing from birth, but we know that they don't come from birth. It's an overuse syndrome. There's a hereditary or genetic component to it. Right? It's virtually, I wanted to say it's never seen at birth, but you never say never in the world of research, because somewhere now or in the past, somewhere there's an exception. But spondylolysis is virtually never seen at birth. Remember the Fredrickson and Butler study. You should know that Fredrickson and Butler study. And here's some more things. So know this stuff here. I would definitely know that. Approximately 25% eventually develop symptomatology. Not 90%, 25%, not all of them. But here's that is a good one. Where did it go? I saw that greater than, look at that number. Greater than 50% of them worsen into a full-blown spondylolisthesis. That's a big number. 50% of them, the ones caught. That's from that Fredrickson Butler study. So study these set of slides here. I'm hitting spondylos very hard in this test. Stress reaction occurs first, or stress reaction, but we could call it reactive sclerosis. Okay, so I would read through this whole section. This thing's already getting pretty big here. And here's an example where we got, it almost looks like an osteoma, doesn't it? So read through this stuff. High yield material. Okay, know the high risk sports. Fast bowlers, that's in cricket. Track and field throwers, weightlifters, gymnasts, American football. I mean, these are very popular sports. So when you have parents bring these type of children in, think spondylolisthesis. It's very common. Not like the general population, which is less common. Should be able to catch that, right? And remember these skip levels. Do they do good with treatment? They have a very bad prognosis. They don't do well. You can clearly see the Scotty dog. There's that dysplastic pars again. Now look at that. That's a definite pars fracture there. Definitely know how to take care of a spondylolisthesis. They're going to come into your office. You need to know what to do with them. You don't give them steroids, right? Or you don't give them NSAIDs. Why? Because NSAIDs, when a bone heals, the first step in healing is an inflammatory process. So if you snuff out the inflammatory process with NSAIDs, you're going to inhibit healing. So their primary doc probably gave them NSAIDs. So you need to call the primary doc because you don't want to interfere with his treatment, and tell the primary doc, you know what, you better perhaps think again about prescribing these to the patient. Or can you just stop? I think you can make the recommendation. It's not practicing medicine without a license. It's common sense. You can't use non-steroidal anti-inflammatories with someone with a suspected acute spondylolisthesis or spondylolysis. My book, grade 5 manipulation is contraindicated. For this test, grade 5 manipulation is contraindicated, period. Don't forget about the zero extension lumbar brace, which needs to be done 4 to 6 weeks. Should be bolded. 24 hours a day. Why do we do that? Because it's a fracture. That's another reason. Do we manipulate fractures? No. Don't manipulate fractures. Okay, physical therapy. Make sure you know you can still do core strengthening, but you should discontinue sport, and anything with extension, you don't do it. So if you want to do bird dogs or something to strengthen the rectus spinae muscle, that's fine. I would read through these as well. Definitely know the two. You don't have to know much, but just know surgical procedures are direct repair, posterior lateral fusion. Buck's procedure is one of the direct repairs. Definitely know this slide. I think we got a better one here. It's kind of the ABCs. Know the Newman and Wilts classifications. Know that the isthmic spondylo, that's the one we probably encounter the most. It is considered a stress fracture of the pars. It can be a pars elongation. We talked about that. It's a cycle of fracture, heal, fracture, heal. Each time you get a fracture, heal, your pars may grow a millimeter or two. If the kid's been in gymnastics for 5, 6, 7 years, they may have fractured this pars many times, so it gets long. So a pars elongation, until proven otherwise, is one of the flavors of isthmic spondylolisthesis. Degenerative spondylolisthesis, we talked about that. The facet, specifically the superior articular process facet, allows the slip, and it's because it becomes so degenerated it can't hang on anymore. Traumatic pars. So that's a fracture of the posterior arch or the facets, but not of the pars. Not of the pars. Because we have an acute fracture. You can get an acute fracture of the pars, which the research says is rare. Pathological. You can read through these, but know these. Iatrogenic. Now this one can get a little tricky. So if you have a patient and they undergo a laminotomy, they have a disc herniation at L4. So what's a laminotomy? It's not a laminectomy. Ectomy means they take the whole lamina out. They can remove the whole posterior arch completely in patients with severe stenosis. But in a discectomy, they have to get in and create a working space. So they cut out about half of the lamina on the side they're coming in at. So that's a laminotomy. So that can set up a weakness of the lamina, and of course they extend that into the pars. You have a weak situation. Now that patient falls on their butt, here's a crack. That's actually an iatrogenic spondylolisthesis because it occurred secondary to a laminotomy. Same thing, if you have a fusion at L4-5 and 10 years later the patient develops a degenerative slip above, then you could call that a degenerative spondylolisthesis as well as an iatrogenic spondylolisthesis because it occurred above something created by man. There's a biomechanical problem created by the fusion. The segment above had to take on way too much work, and that's the story there. So definitely know what that is. Dysplastic, no, those are the big ones, right? Those are the grade 5s. I know what's a grade 5. Know that spondylopatosis, and that is almost always a malformation of the superior articular process of S1. And degenerative spondylos, they never go more than about 30%, right? Definitely know that. And know these population-based epidemiological studies. I could have easily put of the population. This is not a study of athletes. They have shown that the majority of these spondylolistheses are over 50% of them are completely asymptomatic. So you may have plenty of these people walk into your office and spondylolisthesis is just completely asymptomatic. Be careful not to make it symptomatic with a grade 5, right? I never treated spondylos with a grade 5. You could still treat them because the patient may have, because the spondylo and biomechanical changes to the area, maybe they have facet joints that are working too hard above and below the spondylo and they need manipulation. You can use activator, you can use grade 3 manipulation, you can use stretching, you can use physical therapy, you can use exercise. There's a lot of ways to treat them without putting them on the side and doing a grade 5 $1 million roll. I'm sure you're gonna be taught to do things a lot more accurate than that. Some of the physical therapy, though, this we just saw in our seminar last week, our Faculty Institute day, they showed physical therapists doing manipulation to the lumbar spine, and it literally was the most scariest looking thing I ever saw. It was $1 million roll where they they actually twisted the pelvis one way and the rib cage the other way. Why is that not a good idea? The disc annular tears can't stand twisting motions. So it's good thing you're learning to adjust via chiropractic college, in my humble opinion. And if physical therapists are watching this, don't send me hate mail, because I can show you plenty of research where the disc is vulnerable to compression or to torsional forces like that. So not a good way to adjust. Anyway, I digress, and this is already getting way too long. Okay, let's get going here. Remember the magic 7 rule. 7% spondylo, remember this? Basically 100 asymptomatic people, and there's a lot of these. There's bigger ones than this, but I always put this because this was the only one that's ever been published in the New England Journal of Medicine. Really caught the attention. A lot of docs read this. So 7% had spondylolysis, 7% had spondylolisthesis, 7% had central stenosis or lateral stenosis together. Yet they had no symptoms whatsoever. So memorize a piece of the puzzle. Isthmic, you should know all about isthmic. Again, it's real easy to make questions. So know all these little facts here and there. We talked about that already. We talked about those 3: stress fracture, acute fracture, elongated pars. Typically starts in childhood. Talked about that. Again, all these high-risk sports, football, gymnastics, rowing, diving, throwing events. There's that study, Fredrickson, right? And Butler finished it up. But x-rayed 500 kids. There was no spondylolisthesis, no spondylolisthesis found in the newborns, right? Nothing, 0. Then they x-rayed 500 kids. Forget what they were, first, second graders. Where'd it go? There we go, 6-year-olds, so kindergartners. followed for almost 45 years, and know this slide very well, right? 4% of the kids had spondylolysis or spondylolisthesis with, they just said the vast majority had no symptoms. Would be nice to know which ones had symptoms, but most of them had no symptoms. 81% of these had a worsening of the slip by age 25. So that's a crucial factor. These spondylolistheses, this tells us that spondylolistheses that we see in our patients over in the 20s and 30s and 40s, these happened in childhood as a developed as a spondylolysis, and then the slip occurred during same when you get idiopathic scoliosis, where they get that severe worsening during the growth spurt. Same thing can happen here probably when they're getting that big growth spurt. The slip probably occurs, or especially if they're doing sports. What else we got? 50% of those affected reported episodes of low back pain. So half of these kids developed chronic bouts of low back pain over time. 10%, not 90% or 50% or even 30%, which is ridiculous. Even 10% is a huge number. So 10% of them went on to spine surgery. Know that slide cold. Talked about the beak before. I'm not going to go over that again. Greyhound sign. Couldn't find a picture of that, but that's an elongated pars. If you see the greyhound sign, if you match that up, it goes with degenerative spondylo? No. Iatrogenic spondylo? No. It goes with a isthmic spondylolisthesis. Isthmic spondylolisthesis. Spondylopatosis is a complete slip. Know what that looks like. I have a picture in here somewhere. Talked about bracing. Talked about that already. Interbody fusion, right? Here's a spondylo. How come they didn't fix it? Look, it's still there. Very hard to surgically reduce these. They might get them maybe 10 milliliters or so, but they don't always completely reduce these. The key is to stabilize them, to stop micromotion of the defect in the pars, micromotion of the within the disc, within the facets. That micromotion is thought to be an irritant, and by fusing it shut, stopping the motion, it's thought that the pain stops. Make sure you know what those markers are. What are those little lead markers? See the three? That's the polyether ether ketone cage. You don't have to know polyether ether ketone, but no, that's the peak cage, or you can just say that's the cage. Degenerative, we talked quite about this already, how it's a failure of the superior articular process facet to stop anterior translation. It's a guillotine. I think I said that already, seldom exceeds 30%. So if you see a grade 4 spondylolisthesis, it's not going to be a degenerative spondylolisthesis. It just can't go that far. This whole posterior arch is like a guillotine. But this can be quite devastating, cause severe central stenosis. And make sure you know the common symptom of central stenosis. Remember, they can't walk more than a couple blocks. Their pain starts in their legs. They have to sit down and bend forward. Make sure you know that. Neurogenic claudication. And version 2, tumors and aneurysms. I can hear you all groaning and moaning right now. I can just hear it. Osteoblastic lesion. That's all you got to say. Osteoblastic lesion. The bone is blown out, probably from metastatic disease. So osteoblastic lesion of L5, 4, 3, 2, 1 of L1. Osteoblastic lesion, most likely secondary to metastatic disease. This is a female who had a past history of breast cancer. What do you think it would be? Metastatic disease from the breast, which it turned out to be. We talked about these big holes. They usually contain what? Dumbbell tumors. And you can't differentiate between a schwannoma and a neurofibroma. So if you see this picture, you can say greatly enlarged intervertebral foramen, most likely secondary to a schwannoma versus a neurofibroma. Now, 5, 4, 3, 2, 1. What's that L1? Conus medullaris. So this one you should know. What is it? Let's blow it up a little. Myxopapillary ependymoma. Myxopapillary ependymoma. They love conus medullaris and phylum terminale. Simple, right? What do we got here? Kind of hard to tell what's going on here. It's obviously a round tumor. It's a little high for myxopapillary ependymoma. But this is the key image. Know this image. That's why you got to know. That's why I spent all that time teaching you what axial images are. Without them, it's hard to understand things. Here's the disc. Beautiful looking disc, right? Nice white nucleus. Corralled by the annulus fibrosus in black. Here's the slingshot. There's the thecal sac way over here. So what do we got? This is a giant dumbbell tumor. It's kind of a lopsided dumbbell tumor, but it comes, you can see it's extradural. It's not intramedullary, it's extramedullary, extradural. And it grows right through the IVF, which it blows out, right? We saw those giant IVFs before. And so what do you call it? Dumbbell tumor. And you can't tell whether it's a schwannoma versus a neurofibroma. Know this slide. I wish we didn't have time to cover this too much, but you're going to see these all the time, and they can be symptomatic. Okay, that's why I taught you how to read MRIs a little bit here. So here's the cut line. It's going right through this divot. It's got a little reactive sclerosis around it. Here's the divot. What is that? That is a Schmorl's node, and they can be symptomatic in patients, especially when it looks ugly like this. And that's also considered a intravertebral, not intravertebral disc herniation. It's a herniation of disc material in through the end plate. Just real bad stenosis, right? Don't forget the slip. These all look pretty similar. It's another one. That might actually be the same one. Multiple myeloma. X-stop. There's a nice one. I'm not going to give you that one. That's like ridiculous. That's too easy to see. Isn't it? It's an abdominal aortic aneurysm. Bilateral dumbbell tumor. What is it? Neurofibroma versus schwannoma. Okay, we already went over all this stuff. Talked about scalping. You don't actually have this. I've already modified this for next quarter, but you can see it here. We talk about neoplasms. This won't be on your test though. You should know the gross classifications though. You have this slide: extradural tumors versus intradural tumors, and you should know the subclassifications of intradural tumors are extramedullary versus intramedullary. And you should know the most common intradural medullary tumor or neoplasm is the ependymoma astrocytoma. The source is Hyatt 2012 Spinal Tumors book. There's our neurofibromas right down there. And schwannomas. Can all of these switch? I mean, there's always exceptions to the rule. These can switch, but typically these are put in these categories, but they can switch. Why do we care about spine tumors? Because they can mimic disc herniation, right? They can compress, and they can cause radicular pain. You don't have this. I didn't give this to you. This is for next quarter. But you can read through it when you have free time because it's so interesting. And then we try to differentiate between neurofibroma versus schwannoma. You should know schwannomas are associated with neurofibromatosis too, especially when they're seen in children. And they are a high-risk malignancy if they're seen in children, not in adults. They're usually not cancerous in adults. But if you do see is diagnosed as a schwannoma, it's high risk for cancer in children. We saw these already. It's a nice picture of it there from Black 2005. I think I showed that in class. That's a dumbbell tumor. See how it squishes? It's not intramedullary, it's extramedullary, extradural, on top of the surface of the dura. Kind of a neat picture. Yeah, you should know this, right? This is the left side of the body. This is spleen. You shouldn't be able to see a spleen like this. It's actually a patient with a leukemia. There's the liver, huge liver. If you haven't seen the new cadaver, uh, they actually have hepatitis and cirrhosis from drinking, and they had some kind of leukemia as well. And the liver is huge. So come on by the lab and I'll show you the leukemic, is that a word? Leukemic liver. Definitely need to know a little bit about aneurysms. So here's another one of these slides. So easy to make questions from slides like this. Which of the following statements are true about abdominal aorta aneurysms? If the aneurysm ruptures, it carries a 5% mortality rate. No, 90% mortality rate. You're going to die if this thing ruptures. That's why it's maybe to take the risk of treating it, it might be worth it. Males, not females. It likes males. 2 to 6 times more likely in males, not females. Maybe a genetic. Make sure you know the definition. It's a ballooning of the abdominal aorta by more than 50% of its original size. 50% over its normal size. No, it comes off right below the renal arteries is where it's usually found. It can be in the common iliacs as well, or the external iliac artery, internal iliac artery, but the descending aorta is the most common place. The gold standard is not MRI, not X-ray, it's ultrasound is the gold standard. And know that Medicare now pays for this. Medicare pays for this. Know these family histories. This is another one. Easy to make a question out of this slide. Important slide. Etiology is not completely understood. Don't need to know any of this other stuff, but it's kind of interesting. Maybe atherosclerosis is typically present, so might be a clue to the diagnosis. So if you can send your patient, if you're going to recommend that they think about having a procedure, make sure it's done at Stanford or UCSF, a center that sees a lot of these things. Don't go to, I don't even know if there's a hospital over in Lodi or some little tiny place like that. You don't want to have it done there. Mortality rate's about 4%, so that's pretty good odds, especially seeing that if it ruptures, you're going to die, 90% chance of death. So bilateral dumbbell tumor, we've seen that. We've done this. Flying right along there. Oh my goodness, we're almost done. It's over an hour. This could be the record YouTube video, for me anyway. But let's see. So sciatic is really used by lay people. And maybe this statement might be a little strong. I mean, people still use it. The point is, sciatic nerve, where do I even begin to explain this? I like radicular pain. Radicular pain is just a better word for this. See if I can blow that up a little. Radicular pain means that you have a pain radiating from your low back through your butt, down your thigh, and it may stop there. It may go down to your calf, and it may go all the way down into your foot. And it's like a sunburn, stinging, electric type pain. Some patients skip the butt, skip the thigh, it just shows up in the calf. Some patients, it just shows up in the foot. Some people just in the inside of the thigh. It can be very strange, but radicular means it's coming from the nerve root. It's a nerve root level pain, unlike a carpal tunnel syndrome, which is a neuropathy. That's coming from a peripheral nerve. But a radiculopathy or radicular pain is coming from within the spine near the disc. Okay, you can read through this. So radicular pain means radiating lower extremity pain coming from an injury inflammation of the nerve roots at the spinal cord level. Key there. Radiculitis is a bad term. It's a very old term. We should not use that term anymore, even though it still shows up in the ICD-9s and ICD-10s, and they might even have an ICD-9 11 these days, which those are the diagnosis books that you use to bill. But it's not a good term. Remember that. So radiculopathy, again, the key of radiculopathy, you can't just say radiculopathy without doing an exam on the patient. Again, you can't use the term radiculopathy if you haven't examined the patient, or you don't at least know the examination findings. So they have to have positive neurological examination, like loss of deep tendon reflexes, loss of motor weakness, or sensory change. Then you can say they have a radiculopathy. And why don't we want to say who cares about that? Because if you say they have a radiculopathy, that is some serious business. Patients with radiculopathy, they're in for a tough haul. Sometimes they don't recover. I had a true radiculopathy, a 3-level. I can tell you, I never, like to this day, it's 11, 12 years since it started, and I still battle it. So it really sucks. So that's why you don't throw this term around loosely. Okay. And it's very common for people to switch the terms radiculopathy with radicular pain and even sciatica. They may, even on your OSCEs, even the brain trusts who created the OSCEs may not know the subtleties that there is a difference between radiculopathy versus radicular pain versus sciatica. So for my class, you better know these differences, because when you get out in the community, you're going to be a spine expert. I don't want you to screw those up. But for tests, even the boards, they may not make that be quite as anally retentive as I am about this. So you're going to see a little I would assume that these are AKAs for boards and even for the the OSCE test. Okay, we're clear on that. Let's move on here. Definitely need to know about radicular pain. In order for a nerve root to start generating pain, it's not just about compression. Remember we talked about the strings, those surgical procedures where they left the strings in and they started yanking on things. Got to be a combination of compression and inflammation. Compression plus inflammation equals radicular pain. Okay, here's one of those slides. So easy to make questions, huh? Very easy. So causes of compression: disc herniation, stenosis, central, lateral stenosis, spondylolisthesis. Synovial cyst, let's not forget our friend, like the ganglion cyst of the wrist. You can get a synovial cyst of the facet joints. It can compress, and it can eventually start to cause an inflammation of the nerve root as well. Tumor of the nerve root sheath can do it. Fracture, the beak of the spondylolysis. I should probably have put the beak there. I'm not going to do it because we're already way over time here. And then some circles believe that the evil biochemicals that can leak from a degenerated disc through an annular tear, called cytokines, they are so evil that in some patients they can actually cause a true radiculopathy without compression. So technically, patients can have true radicular pain, a true radiculopathy even, yet they don't have any nerve root compression. It's weird. We don't completely understand it. I've seen it time and time again. I actually, remember I said I had a 3-level radiculopathy, yet I only had a single nerve root being compressed. I had a huge annular tear at L4, so I believe I am actually one of those people who am sensitive to these chemicals, because there's no other way to explain. My S1 radiculopathy was explained, but not my L4 and L5. And the only way it could be explained is a huge annular tear adjacent to both of those nerve roots. So I'm a believer in this theory. And there is research behind this too. So go to my website. I have this stuff footnoted there. Do you need to know tumor necrosis factor alpha? No. Cytokines is fine, but that's the ringleader if you want to research that. That's the key one they've been working on for many years now. Here's another one of those slides, right? Ooh, easy to make questions out of a slide like that. Affects 5% of all humans at least one time in their life. Typically loves the 40s, right? 44 is classic age of all outcome studies. Uh, the first tack will recover in about 70% of people, 60, 80%, but 10 to 15% of those supposed complete recoverers don't really completely recover because they have relapses throughout their lives. And definitely know, we talked about severe sciatica, which requires hospitalization, has a very poor prognosis. These people don't do good with conservative care, they don't do good with surgery typically. It's just a bad omen here. Risk for radicular pain, genetics is in there. Make sure you know these are classic questions, board questions here. That what are risk factors for developing of radiculopathy, radicular pain, or sciatica, as they'll call it. Heavy manual labor, and confusingly, or ironically, sedentary work where they just sit on their butts all day, just as high of rate of herniations as manual labor. So truck driver, we talked about road vibrations. The disc doesn't like that. It can rip open the disc just from those vibrations, it's thought, or prevent healing. Best occupation is something where you exercise a little bit, you're up and down, moving around. We know that most common cause is a herniated disc. And then we went through this tutorial here. I don't think I want to do that again. You could follow it. But no, this is a disc bulge, right? A disc bulge is a general outpouching of the back of the disc. Secondary, because the disc is probably degenerated because of that, amongst other reasons, because the feeding system got disrupted, or sometimes an annular tear can cause degeneration. We don't understand why. If you want to create a black disc on MRI or degenerated disc in animals like sheep who have a very similar disc to ours, just all you got to do surgically stick a pin. Just poke the disc. Don't even have to go more than a few millimeters in. And about 80 to 90% of those discs will be black within 6 weeks. And that little pinprick will turn it into a full thickness tear. So is it a good idea to have intradiscal injections done where they stick a hole in the disc to inject a steroid? No. And we know there's human studies now where medical students underwent a disc stick. They underwent a discography procedure where they pumped up the disc, injected contrast, and just to see what would happen in patients with no low back pain. They followed them. Eugene Carnegie from Stanford did this wonder. That guy has some of the best research out there. But he did a study about 10 years later. These students who got these sticks in the disc were not doing well. That more of them had back pain than the normal population. More of them had underwent surgery than the normal population. And that study was, they followed it with aged, sex matched, and morphology matched other people. So a very good study. It's on my website. I reviewed it there. I digress again. What's this? If you see a picture of this, well, the disc is bulging, but now we can see an actual annular tear. And this is a full thickness annular tear. Full thickness annular tear because it's went all the way through. Is this symptomatic? Yes. Where's the patient feeling the pain probably? In the low back because it's stimulating these nerves. It's inflaming them, irritating, compressing them. Who are these nerves? Sinovertebral nerves. You don't need to know the pain route of transmission, but they're probably not going to have, they might have a little referred pain into the thigh, posterior lateral thigh, but probably not all the way down the foot, unless maybe this thing is leaking, right? And these are really getting soaked. But what's this? Good. Herniation is a parent category, but you got to be more specific if you see this picture on the test. This is a disc protrusion. Why? Because it's still the purple or the blue posterior longitudinal ligament here is still contained. It's not ruptured. Kind of hard to see on MRI. But you can also measure the base of the herniation is wider than the height or the posterior poking outness. Is that a word? Poking outness of the disc herniation. So this is a protrusion, aka contained disc herniation. I would definitely know those words. Some of the local MRI centers still use that term subligamentous herniation. I very rarely see it though in the rest of the states and in the rest of the world, but it is out there. Next, worsening. Now we have a much bigger herniation here. Now the base is about the same as the poking outness. These the posterior extension of the disc, if you want to be technical, but it's pretty. This might actually be a little bit deeper here. Kind of hard to tell here. I could have made this a little more narrow, but the posterior longitudinal ligament is gone. If the disc herniation is over 6-7 millimeters, it's an extrusion for the most part. So this is a disc extrusion. I think some people call it an extra ligamentous, but I don't think I've ever seen that except locally, so I wouldn't use that term. I'd call it a disc extrusion. Now what's this patient going to have? Remember we talked about this. When the disc completely ruptures, now the pressure is taken out of the inside. It's like pulling out a sliver. All these pressurized nociceptors of the sinovertebral nerves, that pressure is released and they're feeling better. But now they're not feeling very good because these nerves are crushed and they probably have really bad radicular pain now. You'll see that. You're treating the patient low back. Low back all of a sudden gets better and now he's got radicular pain. And this is a sequestration. Now the disc is just a piece of it's broken loose, and that's the fragment. And this is a disc sequestration. All three of these, protrusion, extrusion, sequestration, are herniations. Those are herniations. This is not a herniation. Okay, and are we done? I think we are about done here. Lateral stenosis, kind of hard to see there. You can see here, there's a cut. The side's open. Neuroforamen is open. The MRI is not that good. You should be able to tell diagnosis though. What's the diagnosis here? Patient's got severe left. This is the left side. I would put that on the test so you wouldn't have to know it, but this is left. Severe left sciatica. So this is all lateral. It's just a mess in here. You can see here's a cut through that side. We got a herniation in here. There's some scar tissue mixed in here probably. But most importantly, what's causing the lateral recess stenosis? Slip. Another slip. Here's the superior articular process facet way back here, and it's left this one in the dust. There's the whole arch, vertebral arch. The wishbone is slid this way, slid forward. And this side too, right? This is a nice one. Both sides have slipped. So this is a degenerative spondylolisthesis. My goodness, I think we're about done. And this is a long review, but I just wrote the test, and if my memory holds up, you should do very well if you study this review. All right, I wish you the best of luck on the test, and we will see you on Thursday.